neurology of sleep and wakefulness. His current research interests include identifying how loss of orexin signaling results in sleepiness and cataplexy, how orexins affect breathing, and development of new medications for narcolepsy. Thank you, Dr. Scammell, for joining us today at our webinar. I'm going to hand things over to you now.
Great. Thank you very much, Claire, for the nice introduction. As many of you may know, this is a very sort of busy area in the field of narcolepsy and idiopathic hypersomnia right now. And so we felt it was sensible to have a talk focused only on this. And I just want to start off by saying I do some consulting with Takeda, one of the companies working in this space, and I work on some of this stuff in my lab. And I don't want you to come away with the impression that this is like the only interesting thing. There's lots of good stuff that's happening in the narcolepsy and IH field, but this talk is focused on that. And to give you an idea of why orexin agonists are appealing, I first want to just start off by talking about the connection between normal orexin signaling and narcolepsy. So narcolepsy was first described in the 1870s, and it was only in the late 1990s that it was found to be connected to a particular neurotransmitter in the brain. And the reason it took so long was because that neurotransmitter was only discovered in 1998. And so one group called this orexins, another group called it hypocretins. And these are signaling molecules. They're neurotransmitters in the brain. And, you know, neurotransmitters essentially excite or inhibit neurons. And in this case, you have something called the messenger RNA, preproorexin messenger RNA, that gives rise to two proteins, orexin A and orexin B, which are also known as hypocretin 1 and 2. And the reason we have different names is just because these two groups were working simultaneously, and the two names have been rattling around the literature. The orexins bind to the orexin receptors, OX1 and OX2, and they have excitatory effects on their target neurons. The orexin neuropeptides are made only by a little cluster of cells in the lateral hypothalamus. And on the right-hand side, you can see the cover of a journal called Cell. And this is the first description of these. And so these white dots show you the neurons that are making orexins. And in the human brain, the pattern is much the same. This is a section of a mouse brain, but the hypothalamus is, as best we know, the only place in the entire body that makes orexins. So these orexin neurons are, you know, the cell bodies are there, but they send these little tendrils, these axons, all over the brain. And they have excitatory effects on many, many things, including the circuits in the brain that control wakefulness and that control REM sleep. So orexin levels vary over the course of the day. The best data we have on this is from monkeys, where their sleep patterns are much like humans. They're awake during the day, they sleep at night. And what you can see on the left here is a new sort of very precise way of measuring orexins, where they collected spinal fluid right from the base of the brain. That's called the cisterna magna. So this is, in purple, is cisternal cerebrospinal fluid. And they also collected spinal fluid in the usual way, which is from the lumbar region in the low back. And the patterns are similar. But what it shows is that over the course of the daytime, starting at 7 a.m. until 7 p.m., orexin levels rise in a roughly linear fashion. They fall steeply at sleep onset when the lights turn out. And they are lower, but they're not zero during the night. They go to about a third of their maximum levels. On the right, you can see the pattern of activity in the orexin neurons. And this is sort of a busy slide, but I just wanted to show you some like real neuroscience data here. And you can focus on the bottom recording. This is showing levels of calcium in an orexin neuron. And when calcium is higher, that means the cell is active. And up top is the ways that we record sleep in mice and humans with the electroencephalogram and the electromyogram. And so these orange regions here are periods of wakefulness. And so you can see that the calcium levels in the orexin neurons are higher during those periods of wake. And so what this slide shows is two things. Orexin neurons are active during wakefulness. And over the course of the day, orexin tone, orexin levels gradually rises and then falls steeply across the night. So the connection to narcolepsy was made a little more than 20 years ago, and Emmanuel Mignot gets a lot of credit for this, having done some of the first measurements. And what we now know is that orexin levels are generally sort of in the 300 picogram per milliliter range in healthy controls, but there's quite a wide variation even in folks who don't have sleep disorders. Levels are very low, 90% of the time in narcolepsy with cataplexy. This is also known as narcolepsy type 1. And levels are usually normal in narcolepsy without cataplexy. And I'm sorry, I should have added on IH here too, but in people with idiopathic hypersomnia, levels of orexin are also normal. So the current way of thinking about these sleep disorders, the real proper clinical definitions are shown on this in the next slide. We now recognize two types of narcolepsy. The shorthand is NT1 and NT2, and narcolepsy type 1 is the traditional narcolepsy with cataplexy. People with this disorder have chronic sleepiness, and they have cataplexy. And if you do a multiple sleep latency test, which many of you have probably been through, where you're taking naps across the day, it's considered a positive test, meaning that the person, you can see it at the bottom, falls asleep in less than 8 minutes, and at least 2 of the naps, if not more, contain REM sleep. Another way you can diagnose narcolepsy type 1 is to measure orexin levels in spinal fluid. And we do that, I don't know, 4 or 5 times a year in my clinic. It's not necessary all the time, but it's something that we find helpful on occasion. So, by the way, I think something just popped up in chat, and I'm going to try to deal with the questions at the end. So please feel free to type stuff into chat as we go, and then we'll get to the questions. So in narcolepsy type 2, it's diagnosed, again, by the presence of persistent sleepiness and a positive multiple sleep latency test. Orexin levels are normal, so we would almost never do a spinal tap in narcolepsy type 2 because it's going to be normal. It's not an especially helpful thing to do. Idiopathic hypersomnia, is another condition that causes people to be chronically sleepy, but it's got a different feel to it, right? A lot of people with idiopathic hypersomnia tend to sleep for long periods at night. Their naps are long during the day. They have a really hard time waking up in the morning oftentimes. Not everybody falls into that, but there certainly are some people who can sleep very long times. And so the definition in this case is IH is people with chronic sleepiness. And as I said, sometimes they have this problematic morning sleep inertia or trouble waking. And the multiple sleep latency test gives you some objective evidence of sleepiness. So again, they fall asleep in less than 8 minutes, but they don't have the same degree of REM sleep dysfunction as you see in narcolepsy. And so instead of having REM sleep in 2 or more of the naps, they might have no REM sleep, or maybe it would just be in 1 nap. That's important. In general, REM sleep is not out of control in IH as it is in narcolepsy. Another way of supporting this diagnosis is to show that somebody actually is consistently sleeping more than 11 hours. And you can do that with a long sleep study. And we're starting to do that in our lab now, where we'll have people just sleep as much as they want and not worry about the MSLT so much. You can also do it with sleep logs. You can do it with actigraphy, which is basically, a wristwatch type device that measures activity. But getting objective evidence of persistently long sleep times across multiple days, I think, is a really important thing to strive for. So, in idiopathic hypersomnia, as I mentioned, the naps tend to be long and unrefreshing. And the hallucinations and sleep paralysis, which are common in narcolepsy, are uncommon in IH. And so it's got a different feel to it. So this table summarizes these clinical features. And for those of you who with a sleep disorder, you can sort of think about where you fall. And it's not always this tidy. I'm trying to make it look really simple here, but the truth is real life is complicated. Daytime sleepiness, of course, is present in anybody. NT1, NT2, IH. That's clear. Cataplexy is only in NT1. That's also very clear. Orexin deficiency, same thing, only in NT1. If somebody's orexin deficient and they seem like IH, we would diagnose them with NT1 just because that sort of trumps everything else. 2 or more sleep onset REM periods is considered suggestive of NT1 or NT2. But if you've got that on your multiple sleep latency test, then you're not going to have IH. That's just the way it's defined. Long sleep is uncommon in NT1 and NT2, but pretty common in IH. Sleep inertia, you see it sometimes in NT2, but it's pretty common problem in IH where people have a hard time getting up in the morning. And there's a gene that we use as a marker for narcolepsy called HLA-DQB1*0602. It's seen in over 90% of people with narcolepsy type 1. It's seen in 50% of people with narcolepsy type 2. But in IH, it's just seen at the same prevalence as you get it in the general population, which is between 12 and 25%. So it's a very useless test in IH unless, again, you're trying to sort out whether there's sort of a narcolepsy angle to things. Okay, so here's the reason that we're talking about orexin agonists today, which is that there's just, ongoing problems with the current medicines. The medicines are pretty good, but there's definitely room for improvement. And so this is a survey Kieran Maskey did a few years ago, asking people with narcolepsy type 1 and type 2 how they were doing on their regular meds. And 75% of them were still sleepy in the NT1 group and 88% in NT2. And about half of them had cognitive problems. The NT1 people were still occasionally bothered by their cataplexy. Fatigue and disrupted sleep were still ongoing problems. This study was done a few years ago before solriamfetol and pitolisant came out, but you can see the breakdown of the meds that people were taking down there. So anyhow, like I said, we got some good meds. We can definitely help people, but we'd like to be able to do even better. So this is a table showing a lot of the meds that are now under development. And as Claire said in the beginning, this is an amazingly busy time in the world of narcolepsy and IH research. Honestly, if you go back a few years, there'd be like a clinical pharmacology study, maybe one or two going on at any given time. And right now there's lots of them. And it's great because it's good for patients, by sort of going at this on multiple fronts. Our hope is that some of these meds are going to really come through and deliver, but it's a long process. And when drugs are under development, the drug company first does phase 1 studies to make sure they're safe and that they work. They do phase 2 to convince themselves that the drugs really work. And then they do the big phase 3 part where they recruit typically hundreds of subjects to really make sure that the drugs are clearly effective and that they have good safety. Every drug's going to have some side effects, but you got to really look at that ratio of overall efficacy to safety. And I'll show you some bumps in the road that have occurred over the last year or two, just to give you an idea of how things can go well and not so well. I've broken this table down into 2 general groups. Up and top in the blue are meds with, some of them have sort of conventional mechanisms of action where they're altering the levels of classical neurotransmitters like norepinephrine and dopamine in the brain. Reboxetine is well along and it may receive FDA approval for treating cataplexy in 2026. Mazendal is also sort of late in development. It's been around in Europe for a while. And the mechanism that I think we can really count on with that is that it blocks the reuptake of dopamine, norepinephrine, and serotonin. There's some claims around whether it does something to orexin signaling, but I don't think the science is terribly strong for that. So I would really look at Mazendal as just another drug that manipulates some of the typical neurochemicals. I'm not going to get into some of the other ones on here. Talking about clarithromycin is a whole talk in its own right. But it's been around for a while. It seems to subjectively help people, but it's harder to get objective evidence for that. The ones all labeled in the pink colors down at the bottom, as you can see, are all agonists of the orexin 2 receptor. What this means is that when they bind to that receptor, they activate it. And so they're mimicking the effects of the natural orexin signaling. Companies have chosen to target the orexin 2 receptor because that's the one that seems to have the strongest wake-promoting effects and the greatest effects on REM sleep. And as it turns out, it was a pretty good guess. You can see that these drugs are being made by Takeda, Alkermes, Centessa, and some other companies. Merck did have a program, but they just recently stopped it. And I'm not sure if they're going to come back and work on other stuff. Takeda, Alkermes, and Centessa are the ones that are furthest ahead. And I'll share a little data from those companies. All right. So, the appeal of these orexin agonists is that they're really addressing the fundamental problem in narcolepsy type 1, which is orexin deficiency. And so, if you can get orexin tone restored in the brain at the right levels, at the right times of day, you should be able to get people feeling pretty good. Now, because these drugs turn out to be so effective for improving alertness, there's hope that they'll also be useful in NT2 and IH where people are not orexin deficient. And there's also other disorders where there's some very mild partial orexin deficiency, like Alzheimer's and Parkinson's, and sometimes traumatic brain injury, and it could be useful in those people as well. As with any new drug, you know, the hope is that it avoids some of the side effects that we're familiar with other meds. But of course, it's a new class of medicine, so it could produce some unique and weird side effects. And as you'll see, there are a couple that are worthy of comment. And importantly, all these drugs that are in development are just targeting the orexin 2 receptor, but not the orexin 1. And that is probably okay, but it may be relevant. And I think I have a little bit to say on that at the end. All right, so let's just go through this in sort of a historical fashion. The first real clinical data on this came out about 3 years ago from Takeda, and their first drug was something called Danavorexton. And this is a very good activator of the orexin 2 receptor, but it has to be given intravenously. So it's not useful for day-to-day clinical use, but it's a nice way to demonstrate that this general kind of medicine can work. And what they did is they tested this medicine in narcolepsy type 1 and narcolepsy type 2 patients on the maintenance of wakefulness test. Now, this MWT test is one that's the opposite of the multiple sleep latency test, which some of you have had. On the MWT, people are instructed to sit in a comfortable chair in a dimly lit room for 40 minutes and don't fall asleep. And they got to do that 4 times across the day. And this is a really tough test for people with narcolepsy type 1 who are on no medicines. And so in the gray line here, on day 1, you can see that people are falling asleep in 2 or 3 minutes. On day 7, the people who got placebo, it's the same thing. But the people who got the high level of the drug, 44 milligrams, stayed awake for the entire 40 minutes on both day 1 and day 7. The people who got a lower dose, the 11 milligrams in red, the drug worked pretty good on the first day, and it still worked very well, though, you know, a little bit more variable later in the day. In narcolepsy type 2, you can see largely similar results, where the placebo-treated people were falling asleep in 5 to 10 minutes in gray. And in this case, they used higher doses in narcolepsy type 2 because people with narcolepsy type 1 are probably exquisitely sensitive to orexin drugs because they're lacking orexins. And so they gave 44 milligrams as their low dose in blue and 112 in purple as their high dose. And what you can see is that the results are kind of similar. You can get pretty good improvements, 20 to 40 minutes staying awake on the MWT in narcolepsy type 2. This is showing the results in people with idiopathic hypersomnia with this, again, intravenous experimental drug, Danavorexton. And so here, placebo treatment, falling asleep in 10 minutes. With drug at that higher dose, they are staying awake for the full 40 minutes. It's pretty impressive. I'm going to talk more about side effects and stuff like that in a little bit because we have some better data than this. Importantly, these studies that I'm just showing you are really small, okay? So on this one, 13 patients. On this one, 12 patients, all right? So take it with a grain of salt. This is just preliminary stuff. But it shows such a magnitude of improvement that it encourages the companies to move on and try this in bigger groups of patients. So this paper got a lot of attention when it came out in New England Journal a year and a half ago. And this is the next drug in Takeda's pipeline, TAK-994. And this was an oral drug. And people were taking this for a couple months, and then they went into a long-term extension because they could take it for several months more. And again, the main endpoints here are looking at how quickly somebody falls asleep on the maintenance of wakefulness test, how's their subjective sleepiness as measured with the Epworth sleepiness score, and how much cataplexy are they having each week. And so what you can see is here that the placebo-treated patients fell asleep on the MWT in 4 minutes, but with the drug at low, medium, and high doses, they're staying awake for 30, 35, or 39, well, basically 40 minutes. The Epworth sleepiness score went from about 14 minutes down to low single digits, 5, 4, 1, something like that, which is, again, really encouraging because this is a level of subjective sleepiness that's well within the normal range. And the number of cataplexy episodes went from about 10 or 11 down to just 1 per week. And so this is just super encouraging. Subjectively, people really, the doctors and the patients all thought that this was working really great. But the problem was it had to be stopped. First, and this wasn't why it was stopped. It was people had some side effects that were not entirely anticipated. They're not ones that we generally see with some other meds, like urinary urgency and frequency. Feeling like you have to go to the bathroom was pretty common. And you can see at some of the higher doses, this was occurring in like 30 to 50% of patients. Some people also had troublesome insomnia. Some people had sort of excessive secretion of saliva. But what really caused the problems was the liver toxicity. And so down here, you can see that about 11 to as much as 20% of patients, shown in the parentheses, developed some liver inflammation. And this was felt to be a very weird reaction to the drug. We don't think it has to do with orexin signaling. It was something peculiar about just the shape of this drug that the body reacted to. And so even though clinically this drug was looking really pretty good, the side effects were just too dangerous to proceed, and that was stopped. And so this is the drug that's now under development for narcolepsy type 1 from Takeda. It's called 861. And this is data that was shown last fall at the European Sleep Meeting. And this is a drug that can be taken once or twice a day. And so the groups here are placebo in gray, a low dose of 0.5 milligram when you get up in the morning, and 0.5 milligram 3 hours later, or 2 milligrams plus 2 milligrams 3 hours later, 2 plus 5, or all 7 milligrams in the morning. And again, we're measuring sleepiness with the maintenance of wakefulness test. And people are at baseline, when they're off medicines, they fall asleep in 3 to 6 minutes. But at week 8, after being on the drug for 2 months now, they're staying awake for 16, 27, 30, or 19 minutes. And what's interesting here is that the middling doses actually seemed better than the highest dose. And we don't really understand why that is, but these are the doses that are likely to be moved ahead, the 2 plus 2 and the 2 plus 5. And these are good numbers. Staying awake for 27 minutes or 30 minutes is really quite respectable. This is showing subjective sleepiness. It's measured with the Epworth sleepiness score. At baseline, with no treatment, people had pretty solid sleepiness, Epworth scores of 18 or 19. And then with treatment, again, those middle doses, the Epworth scores are only about 5, which is fantastic. That's a very good level of alertness. The last thing that they did, which I think is really interesting, and I'm glad to see research going in this direction, is to look at cognition. And in this case, they use something called the psychomotor vigilance test. This is a test where, you're looking at a computer screen, and every time there's a little light, you have to push the button really fast. And so, in one way, you can measure performance looking at how quickly people respond. But more importantly, we want to understand brain fog and lapses in attention. And so if you look at the number of times that people miss the stimulus, the light flashes and the person doesn't push the button, that's a good measure. And what you see here is that at baseline, whether you're looking at the morning or the afternoon, across all these groups, people were missing the stimulus about 15 to 20 times during the 10-minute test. With treatment, they tested again in the morning and afternoon, but basically across all these doses, the number of lapses went down quite a bit, down to 6 or 10 thereabouts. And I don't think there's a big difference between the doses. Oops. And so I like this a lot because it's really, to my knowledge, one of the first clinical trials where they've really looked hard at objective endpoints of cognition. I think this is a step in the right direction since cognitive complaints are such a big concern for many people. And you might notice here that I put in a dashed line for what I think is about a normal response. 2 or 3 lapses is probably about normal. And sometimes these people are getting down to that range, but it's not perfect. They're better cognitively, but it's not exactly completely normal. Okay, so this is pretty important. So Takeda has now finished what's called the phase 2 study, which was 2 months long. And then people, if they wanted to, could roll on into what's called the long-term extension, where they then can take the drug for an additional 6 months. And so, and if people were on placebo, they would get switched to the drug itself. So one thing that I thought was really interesting is of the people who were in the phase 2 study and completed it, 95% of them wanted to go on to the long-term extension, which I would consider evidence that they felt like they'd rather be on this study drug rather than on their regular medicines. They had the same frequency of side effects is in the other stuff. So frequent urination, urinary urgency were kind of a concern. My impression with these is that it kind of feels like you've just had a few cups of coffee and need to run down the hall more often than not. Also, the drug does kind of have a longish half-life, a long duration of action. And so insomnia was a problem for some people, though for most folks that settled down after the first week or so. So on the right, what you can see is that the maintenance of wakefulness test results look just as good in the long-term extension as they did at the end of month 2. And so people were staying awake for something in the range of 20 to 25 minutes, even at the end and across all the different doses. And the number of cataplexy events per week was also remained quite low. So that's nice because it shows that this isn't just a fleeting thing. The drug continues to work across time. So of relevance to people both with narcolepsy and IH, I think an important question is, well, what about nighttime sleep? The orexin agonists are all basically going to be taken in the morning with the goal of really trying to improve alertness. And there's two things that have to be thought about. One is, might these last long enough that they interfere with nighttime sleep? Or, what about all the spontaneous awakenings and stuff like that occur in NT1, or the difficulty waking in the morning in IH? Is it going to help those at all? And the short answer is we don't really know yet, but this is the beginning of evidence along these lines. And so up top, what I want you to take a look at here is if you break an 8-hour night down into quarters, so 2-hour chunks, in healthy controls shown in the striped bars, the amount of REM sleep gets to be greater and greater by quarter of the night. So you're spending more of your sleep in REM sleep in the fourth quarter than in the first quarter. But in narcolepsy type 1, you don't see that progression so much. They have more REM sleep right in the first quarter than the control population. And so what this slide is showing is that at the bottom is that, and I focused here just on the 2 main doses, the 2+2 and the 2+5 dose. When you compare baseline and week 8 of treatment, what you see is a suppression of REM sleep in the first 2 or 3 quarters of the night compared to the untreated baseline period. And so what the drug is doing is it's producing a more normal distribution of REM sleep. Now, this is just a physiologic feature. I don't know yet whether this is going to make any difference subjectively to people. Like, are they going to have less vivid dreams? Are they going to have less, nightmares and stuff like that? That we'll have to see over time. But at least in this little study, like in terms of disturbing dreams, at baseline, people were having 2.8 bad dreams per night. And across all the doses, it was about 1.3 nights. And so maybe that's helpful in that regard. Because in the end, when it comes to sleep, I think people's subjective perceptions are more important than anything we can measure with all the wires and whatnot. Okay, Alkermes is another company that's doing very well making orexin agonists. And so here's one of their drugs. It's called 2680. And this shows that this drug also can do great things on the maintenance of wakefulness test, where, at baseline or with placebo, people are falling asleep in 4 to 6 minutes, but they're staying awake for 25 to 35 minutes with different doses of the drug. Importantly, Alkermes is in the early stages of their research. And so this is a study of only 10 subjects. And they only took the drug for 1 day. And you might remember in one of the early slides I showed is that with that intravenous drug, it looked fantastic on day 1. And at least at the medium dose, it wasn't quite as good on day 7. So, take it with a grain of salt. We're only looking at 1 day's data here. Importantly, they saw the same kind of side effects that's been reported by Takeda: insomnia, frequent urination, and so forth. So I think this is probably what we call a class effect, meaning that if you give people orexin agonists, these are the kind of things that are likely to pop up in almost any study. This is data in narcolepsy type 2. I haven't shown you as much of this. And this, again, is a small 9-subject study from Alkermes, same drug. And here they're using somewhat higher doses because people with NT2 and IH need higher doses probably of these meds. And again, what you can see is that people are falling asleep in 14 minutes if they're on placebo or at baseline, but they're staying awake for 26 to 35 minutes with the drug. Same kind of side effects as we just talked about. And this is people with IH. So this is 8 subjects, again, 1 day of treatment where they cross over between the different doses. And interestingly, you remember how we talked about how the features of IH are a little different in narcolepsy, people can fall asleep really fast. That's not always the case in IH. And so even off treatment, people with IH are staying awake on this test for about 20 minutes. But then the drug helps them stay awake for even longer. So 29 to 38 minutes with the various doses of the orexin agonist. And so this shows that the sleepiness of IH is not quite as imperative as in narcolepsy, at least for some people, but that the drug can actually still produce further improvements in alertness. Okay, so I've shown you a lot of stuff, and as you can probably tell, I'm pretty enthusiastic about this, especially in narcolepsy type 1, but I do want to point out some limitations. The drugs that are being developed now target the orexin 2 receptor, but natural orexin signaling hits both OX2 and OX1. And so it's really unclear just how much and just which symptoms of narcolepsy type 1 are actually going to improve. I mean, I've shown you some stuff, right? People are clearly able to stay awake better. The cataplexy is suppressed. But, what about some of the other things, the disrupted nighttime sleep, the depression, anxiety, some of the other features, the overweight, things like that occur in narcolepsy. Are those going to also improve with an orexin 2 agonist? We don't know that yet. Also, when you're giving somebody a pill in the morning, the drug levels that you get with that pill may not completely reflect the normal variations in orexin tone. You might recall early on, I showed you orexin levels in spinal fluid of monkeys and how it rises across the day. And, it'd be great if we could replicate that, I think. But how important is it to match that with these medicines? I already mentioned that it's unclear if these are going to actually improve sleep. I showed you some evidence on what happens with REM sleep, but again, I think what people experience is going to be the most important. And I hope that as these things move along, some of the companies will focus more on cognition, obesity, depression. Oh, and people with narcolepsy type 1 are also more prone towards having high blood pressure. What's it going to do there? I'm not aware of any bad effects on blood pressure with these medicines just yet, but there hasn't been a lot of info. As I mentioned before, I'm very excited about orexin agonists in narcolepsy type 1, but how well are they going to work in people who already have orexin signaling, NT2 and IH? And what are the consequences of pushing orexin tone a little bit higher in those folks? It's clear that you can keep people awake more, and that's all great. But are the side effects going to be more common? Is there going to be some other issues we need to wrestle with? So we've got to watch out. So this stands for, will higher doses be needed, and will this come with more adverse events or side effects? That's what that stands for. And this is important. In people with idiopathic hypersomnia, long sleep time and morning sleep inertia are usually bigger concerns than the daytime sleepiness. Some people with IH say, well, once they get up, get dressed, get their breakfast, it's actually that they've gotten through the worst of it for the day. And after that, it's not so bad. And are these meds really going to be helpful on those particular symptoms yet? And I don't really, I even just sort of from a neuroscience hypothetical point of view, I'm not sure why those morning symptoms should necessarily improve with an orexin agonist. They might, but I think this is something that's going to have to be examined very carefully. All right, so here's my last slide. The current meds that we have are pretty good. I hope most of you are feeling like your meds are reasonably well tuned up, but there's still some room for improvement. Orexin receptor 2 agonists can produce large improvements in sleepiness and cataplexy in narcolepsy type 1. I showed you some very early data with just small numbers of subjects showing that it's at least possible that we're going to see improvements in NT2 and IH, but we need bigger sets of data. The things to watch out for with these meds are insomnia and frequent urination. As I said, the insomnia generally seems to fade after the first week or so, and the solution around that may be just to start with a low dose and just tiptoe up gradually. I don't think the urination is sort of a deal breaker for most patients, but everybody's going to be a little different that way. And Claire mentioned that the Hypersomnia Foundation website has a listing of clinical trials, and you can also go to the government site called clinicaltrials.gov and just type in narcolepsy or IH or whatever it is you're interested in, and you can see other studies that are ongoing too. And I really want to end with this pitch on this, because these meds are not going to move ahead unless people help by signing up for the clinical trials. And you need to decide for yourself if this is something that you want to do. There's always an possibility of getting in the placebo arm of a study. And there's potential side effects. And, we can't say these things are completely safe until we really study them. But this is how we're going to really help the general population of folks with hypersomnia disorders, is by people participating in the trial. So I hope some of you can think about that. All right, so I'm going to wrap up there, Claire. And I think I saw a bunch of stuff popping up in the Q&A.
Yeah, thank you so much. It's actually quite difficult for us as a community to get that information that you shared with us today. So thank you for that, because it is so hopeful, I think, but there's a long way to go, and you explained that so well. And we do have quite a few questions, so thank you to everyone for putting those in the Q&A. So I'll read the first one then, Dr. Scammell, from an anonymous attendee. So the question is, are there patients diagnosed with both NT2 and IH? Can you explain what that means and how it would even be possible?
Sure.
And are other comorbidities likely explanations?
Yeah, so that is a tough question because we often have I've been taking care of people with sleep disorders for 25 years, and I sometimes have trouble telling whether somebody's got NT2 or IH. There's a huge gray zone between these. In the extreme, if somebody says, oh, I sleep 12 hours every day, I have a horrible time waking up every morning, it's like, fine, you got IH. On the other hand, if somebody says, I'm sleepy, I have a lot of hallucinations, I have a lot of sleep paralysis, I don't have any cataplexy, fine, that's NT2. But most people fall in between, and it's not easy. And we rely a lot upon the multiple sleep latency test and whether it shows the REM periods or not, and that's not a great test. We all know that. We would love to come up with better diagnostic markers because, in the end, we may have I'm not saying this is imminent right now, but I hope someday we have therapies that are really targeted for the very specific needs of patients in these different groups, and we just have trouble with it right now. So yeah.
Okay, thank you. All right, so the next one, is there any correlation between vitamin deficiencies and orexin deficiencies? Is there any evidence to support that vitamin D and vitamin B deficiencies contribute to hypersomnia?
Yeah, so certainly vitamin deficiencies can cause fatigue. And there's some possibility that vitamin D deficiency can be associated with sleepiness. I remember seeing a poster from a researcher in Scotland where there's probably a lot of vitamin D deficiency. I'm looking at Claire when I say this. So yeah, I mean, I think it's possible, but I don't think there's good evidence that vitamin deficiencies usually get to the severity where people will be frankly sleepy on a chronic basis. And also, I don't know of any evidence that vitamin deficiencies can ultimately result in orexin deficiency. So, yeah.
Okay, thank you. Okay, moving on. Many drug trials, this is from Anne, many drug trials have an age cutoff that would eliminate me potentially as a candidate because I am 79. What are the chances of me being able to participate in a trial at my age?
Yeah, well, it's going to depend on the trial. But, I think part of the challenge, and I'm afraid to say, is that when people get over 80, things get complicated. And, for the most part, these trials are trying to enroll people who are relatively healthy. You can't, you'd have to look at what's called the inclusion or exclusion criteria for each one of these. And that's where going to the clinic, I don't know how much detail there is on the Hypersomnia Foundation website, but at clinicaltrials.gov, you can click through and see what the actual criteria are for getting in. And you may find some where they have age limits that would enable you to join in.
Yeah, it's a good question. And also, if you do put in a call and apply, you go through a pre-screening process, so they will be able to answer a lot of your questions in detail. Okay, so next question. Are there any studies or data exploring the connection possibly between childhood trauma or PTSD and hypersomnia? Any data supporting that relationship?
Yeah, so this comes up not too rarely in clinic, actually. I mean, I've seen a number of patients where this is an issue, and I'm not aware that PTSD or trauma directly causes narcolepsy or IH. However, PTSD can certainly be associated with high levels of anxiety and poor sleep, which can then result in daytime sleepiness. And I had a patient recently who actually carried a diagnosis. I can't remember if it was narcolepsy or IH for many years. And then as we really started digging into it, her features were kind of unusual. And we said, maybe this is really related to PTSD. Over the last year, she's been getting therapy for PTSD, and she is so much better. And so And so I think the best way I would put this is that PTSD and high levels of anxiety and depression can masquerade as a true sleep disorder. And it's good to see a clinician who maybe can try to sort of tease these things apart.
That's incredible. Okay, so Jen is curious about the neurotransmitters and connection correlation to depression. As my doctor says in the question, she says sleep disorders and depression go hand in hand. Why is
Yeah.
that? And
Yeah.
how do we know which comes first?
Right. This comes up in clinic every day, right? Because people say, I don't know if I'm depressed because I'm tired, or if I'm, or which way it is it? Because the more tired you are, the more depressed you feel, and then if you're depressed, it makes you feel more tired, and both. So they certainly feed off of each other. And I guess I would say is if there's more than a little depression, target that as well, right? If you have enough depression that you think it's part of the picture and it's not just a minor consequence of your sleepiness, maybe you want to talk to your doctor about getting treated for that in parallel with treatment for your sleep disorder.
Thank you. Dr. Ruoff mentions in his keynote some years ago for the Narcolepsy Network that orexin may be important for IH as well. Is there any research on this
Yeah.
in 2024 and 2025?
I wish I knew what he was referring to.
Yeah.
I think that I honestly I wish I'm not sure I even heard his talk. I think as a first answer, orexin signaling is normal in IH. I think that's the way to think of it initially. I wouldn't be surprised if there's, as you might remember on one of my early slides, I showed spinal fluid measurements of orexin. They're quite variable. And I could imagine there's probably some people with IH who are on the lowish side. And then those folks, it may be a contributing factor. But I think just as a first statement, I'd say IH is not due to orexin deficiency.
Okay. Thank you. In the studies with NT2 and IH, were the subjects getting one dose a day? How many doses were they getting?
Yeah. So the studies that I showed on NT1, some of them, like the phase 2 studies from Takeda, were 2 months long, or in some patients, 8 months long, very long studies. I think every slide that I showed for NT2 and IH was very brief. It was either, most of it was just 1 day of treatment with each dose. Yeah.
1 day. And sort of related to the studies, Cheryl asks, all these studies show minutes that people are staying awake for. Don't we want to stay awake for hours?
Yeah, I like your question, Cheryl. That's good. I think this has to do with the practical limitations of the testing. But to be honest, the MWT is a really miserable test. Sitting in a chair doing nothing for 40 minutes is really, really hard. And our general feeling is if you can do that, you can probably stay awake for hours. Because one would hope that most of our day-to-day life is a little more stimulating than that. And so under more exciting circumstances, you're probably going to be fine if you can stay awake for 35 or 40 minutes on the MWT.
Yeah. Okay, next question. We've got a few more minutes left. I've tried Wakix with no difference for EDS. I've tried Xyrem, Xywav, and Lumryz, and with each I had involuntary flailing of legs and arms and involuntary flailing, and also moaning and had to stop. The doctor said that they all affect my central nervous system. What about the drugs now being researched? Going after orexin, do they have anything to do with the CNS?
Yeah, so first, I sympathize with you. Everybody's a little bit different. Everybody's chemistry is different. Some people have problematic side effects. Some people do great. And I can't speak to your particular circumstances, but to get to your last question, I think we can say with a very high level of confidence that the improvements in alertness and cataplexy that we're seeing with the orexin agonists are due to their effects on the brain. And pretty much all of the drugs that we're using to help people now are having their effects by acting on the central nervous system. Yeah.
Thank you. Alison asks, are the current diagnostic measures limiting in the ability to enroll sleep disorder trials and studies?
That's a good question, because in general, what you're going to find is that all these trials have fairly stringent criteria. They're going to say, because, I can tell you, I have people in my clinic who I'm treating for IH, but they stayed awake longer than 8 minutes on the multiple sleep latency test. I'm treating them because they need to be treated, but a lot of the clinical trials want really concrete evidence. And so if your multiple sleep latency test doesn't quite meet the usual criteria, you may have trouble meeting inclusion criteria.
Thank you. Okay, do we know the mechanism for lack of orexin increasing REM? My sleep doctor gave me a sample of orexin agonist to see if it would help me sleep better at night. I already feel like I spend most of the night dreaming, but the one night I took this medication, it went even more overboard.
Yeah. Okay. So Janet, oh, sorry, that disappeared quickly. So Janet was talking about her experience with an orexin antagonist. All right. So that's opposite of what we just talked about. Agonists activate receptors, antagonists block them. And so orexins normally suppress REM sleep. Orexin agonists suppress REM sleep. Orexin blockers or antagonists can unleash REM sleep. And even in people who don't have sleep disorders, if they just have regular old insomnia, sometimes they can have vivid dreams or nightmares on orexin antagonists. And so if you're already prone towards that, an orexin antagonist could make it worse.
Okay, thank you. I missed Kim. Any data or info on whether these drugs could potentially be used in combination with stimulant needs to supplement if the person still has daytime drowsiness despite these? Or are there anticipated cross reactions so people are limited to either or?
Yeah, good question. And the answer is we don't know because all the studies that have been done thus far, people have completely come off their other medicines. And so, we now use meds in combination a lot. And my guess is that once orexin agonists come out, as doctors and patients gain confidence with those, we'll get a sense of sort of how much flexibility do we have and can we combine them with other meds? I have no reason up front to think that it's a problem, but I think at this point it's hard to make any pronouncements since there's just no info.
Okay. Right, it's two questions wrapped into one from Carrie. My daughter has NT1 and I have IH. My sleep doc said they were not related or genetic. Is that true? And secondly, can quitting smoke and cause symptoms to appear?
Yeah, okay, let's do the first one. Please leave the question up for a sec. My daughter has NT1 and I have IH. So NT1 that can run in families. There is definitely a genetic influence to it, but it's not a huge one. You might know that there's a gene that's very strongly associated with narcolepsy. But even with that, if a parent has narcolepsy, there's only about a 1% chance that one of their kids is going to have it. So that's some reassurance. It's not a strong genetic influence. That's not the case in IH. And so I have to say, it's possible that there is some sort of similar physiology with you and your daughter, in that in one person, it looks a little bit more like IH, and another, it looks more like NT1, but I don't think one can say that she got IH in any connection to you having NT1. The second one is quitting smoking. Well, cigarettes contain nicotine. Nicotine's a stimulant. Nicotine wakes people up. And so it's possible that if you were smoking and then you stopped and now you feel sleepy, you were actually, I'm just going to call it self-medicating with the nicotine, that you're kind of masking the sleepiness that way.
Okay. Sylvia says NT2 and IH often referred to as non-orexin deficient, yet appears to be emerging data of orexin dysfunction. For example, Dr. Mignot group extract at Sleep Houston, where subpeptides differed significantly in NT2 and IH. Is there more work being done here?
Yeah, so I would have to say this is kind of early, and I think I'm not exactly sure which of Mignot's work is being referred to here. This might be sort of on peptide expression of other things too, and I'm not sure if that's been published yet. So to be honest, I talk to him every couple of months, and so I'll check in with him next time. But I don't have much to say on that. But we do have one right above it, which is where's the urinary frequency come up from, and in that we don't really know. There's a theoretical answer. There is a brain region that contains orexin 2 receptors that is involved in urination, and it's possible that the drug is acting on that site as well as other sites that help wake you up. Yeah.
Okay, I was diagnosed with cataplexy, says Amber, but also diagnosed with IH. However, all studies show IH does not have cataplexy.
Yeah. So this gets to that whole clinical murkiness that we have to deal with. Everybody's a little bit different. And so, Amber, I guess the one thing you could talk to your doctor about is it really cataplexy? If your doctor your doctor, hopefully, if they're an experienced sleep doc, would know to ask some questions and really sort of probe if you're having episodes of weakness. Are they truly cataplexy, or is there some features that make them seem less likely to be the case? If it's still ambiguous, a spinal tap and measuring orexin level is often very helpful there, because almost everybody who has cataplexy has low orexin.
Sylvia says, can you tell us more about orexin
Oh.
disruption and how is it connected to Alzheimer's?
Yeah, so there's only a little info on this, but in Alzheimer's disease, lots of neurons in the brain are dying off. And amongst these are the orexin neurons. And so at the end stages of Alzheimer's disease, when people are getting pretty bad shape, there is a moderate, well, really more of a mild loss, about a 30% loss of the orexin neurons. Not the same range as what you see, the 90+% loss in narcolepsy type 1, but there's a partial deficiency. And you know, sometimes when people have Alzheimer's, they also start getting sleepy. And so it's a possibility that some of their sleepiness is related to this. It's something that needs to be looked into more.
I think we've read on our last 2 minutes here. Kate says, is there a genetic link between sleeping disorders? Quite similar to a previous question, but both my parents have one. One has sleep apnea, the other sleep talks. I have IH with long-term sleep. I've only seen small studies, but not a lot on this.
Yeah, so there is some overlap. Like for instance, you know, in people with narcolepsy, they're more likely to have sleep talking and obstructive sleep apnea. Part of that, I think, is because people end up coming to a sleep doctor and they get diagnosed with sort of incidental things. But I do think, you know, the weight gain that goes with narcolepsy can predispose people to sleep apnea. And for reasons that we don't really understand, parasomnias like sleep talking are more common in narcolepsy. So the fact that one of your parents has sleep apnea and the other one has sleep talking probably has nothing to do with your IH, though. I don't know of any sort of genetic or familial tendencies in that way. And by the way, with sleep talking, 30% of the population does it, and we don't really get too excited about it. It's usually more of a nuisance than anything else.
Thank you. Have any of your patients found the timing of when they can take their meds? Would it make a difference?
Sure. This is very important, and it's important in narcolepsy and IH, and it's kind of a whole conversation in its own right. But I think the important thing is to work with your doctor on what time of day are your symptoms most bothersome and adjust the meds accordingly. And so, for instance, if you have a hard time waking up in the morning, maybe taking a stimulant very early in the morning or taking a delayed release one at bedtime might help, for example, in IH.
Thank you. All right. This is rapid fire. We got any, I think we had one more, but it's gone. So sorry for that. Well, I want to thank you. That was so incredibly informative. And the good news for everyone listening or anyone that's missed this, it is recorded. So we will be posting Dr. Scammell's talk just now on our website. So you can re-listen to it, re-watch it there. So thank you, Dr. Scammell.
Okay.
Really
Well,
appreciate you.
Yeah. Thanks to the audience. Those are really great, thoughtful questions. Appreciate it.
Huge. Thank you.
Okay. Bye, everybody.
Day.